Good afternoon, everyone. Our next speaker is Dr. Janice Joo, the Epilepsy Fellow here at the Los Angeles VA and presenting on autoimmune epilepsy.
Hi, yes, thank you. Hi, my name is Janice Joo. I'm going to be talking about autoimmune epilepsy. This is one of the newer topics in neurology that really has emerged over the past 15 years or so. I'll be talking about kind of what we know about it so far, but I do want to preface this talk by saying that there is still a lot that we're learning and a lot of research that is ongoing regarding this topic. So just a brief introduction about me. I am an epilepsy fellow at the West LA VA Hospital, which I pictured here. We are an epilepsy center, which means that patients get referred to us for things such as seizure characterization and surgical workup in our epilepsy monitoring unit. I am in my 6th year of training, which means that I have done my residency in neurology, and then I'm spending a couple years getting more specialized training in epilepsy. So this is just a brief overview of the talk that I'm going to give. I believe it's going to last about 30 minutes or so, but we'll start off with an introduction to autoimmune epilepsy, and then we'll talk a little bit about the pathophysiology or the mechanism that underlies the disorder. We'll then go over common clinical signs, seizures, as well as how we get to the diagnosis. And then we'll spend a little time just talking about a couple specific syndromes before going over treatment options. And then following our conclusion, if anyone has questions, that'd be a great time to ask. So what does it mean to have autoimmune epilepsy? I wanted to first start off with a couple of definitions. The term autoimmune is used to describe a disorder in which the immune system attacks its own body. In autoimmune encephalitis, where encephalitis means inflammation of the brain, the immune system can attack targets on cells in the brain. And in some people, this can lead to seizures. So when we determine that a person has seizures due to an autoimmune encephalitis, we commonly refer to this as an autoimmune epilepsy. So how common is this? The true incidence still remains unclear, but there are some reports that approximate about 6 to 10% of patients who have new adult onset seizures may have autoimmune epilepsy. And identifying this is so important because it really opens up a different avenue of therapy that can change the course of epilepsy. And this is especially true for those people who may go on to develop epilepsy that is resistant to medications. And then I wanted to talk just briefly about the pathophysiology or the mechanism behind autoimmune encephalitis. So as I mentioned before, an autoimmune disease occurs when the immune system mistakenly attacks its own body. Normally, the immune system guards against foreign invaders like bacteria and viruses. It can sense these foreign invaders and launch an attack against them. And one of the ways that our body naturally fights back is to use antibodies. So this graphic here, shows this red ball, which represents a foreign invader, such as the virus. And then it shows these antibodies, which are trying to identify and dock and block these viruses. In autoimmune disease, for reasons that are still a bit unclear, the body creates autoantibodies against normal antigens, which goes on to produce an inflammatory response. And then in autoimmune encephalitis in particular, the antibodies can be against targets that are either on the surface or even inside of a nerve cell. So next we'll move on to clinical signs and symptoms. Essentially, how does the patient present? And what information leads us to consider autoimmune encephalitis? So here I have a nice table, which I found from a paper from the Mayo Clinic, but it essentially summarizes the major clinical findings in autoimmune encephalitis-related seizures. My video is not working. Okay. So the first important clue is the timeline. We typically see a subacute onset of symptoms, which means that the symptoms develop over the course of about 3 months. And there can be a wide variety of symptoms, which can include short-term memory loss, altered level of consciousness, lethargy, personality changes. This can include bizarre behavior. Many patients will develop psychiatric symptoms such as psychosis or hallucinations, where they may see or hear something that's not there. Some people will have what are classified as brainstem symptoms such as ataxia, which refers to losing your balance, dysarthria, which refers to impaired or slurred speech, and dysphagia, which means that the person may have trouble swallowing. Some people will have abnormal eye movements. Autonomic dysfunction can be present, and this refers to unstable vitals, such as fluctuations in vital signs, including blood pressures, heart rate, temperature. Some people may develop abnormal movements, which are called dyskinesias or dystonias. I had a video I wanted to share. Let me see if I can just pull it up separately. One second. I think it's working now. Okay. So this is a person who has autoimmune encephalitis and had developed an eye movement disorder called opsoclonus myoclonus. Oh no. Okay, let's try one more time. So as you can see, he's just got very rapid eye movements at rest and when he's looking around. When he walks, he looks like he may have some tremors, maybe some impaired balance.
Let's turn around to the back toward the opening in the bed. Okay? He's going to turn.
Just going to skip forward a little bit. So then he gets treatment.
Hold my hands from side to side.
You can see his eye movements have now normalized. They're smooth. We don't see any of those weird kind of rapid movements of the eyes.
Any double vision, please tell us.
So yeah, I thought that video was interesting in showing the kind of bizarre things we may see on our exam. So what else? So new seizure is also an important clue to autoimmune encephalitis, especially if it's associated with any of these other symptoms. In particular, the patients can have frequent seizures at onset that are difficult to treat. And in severe cases, patients can develop status epilepticus, which means that the seizure is very prolonged or that the person is having back-to-back seizures. These seizures may not respond to medications, and sometimes we refer to it as NORS, which means new onset refractory status epilepticus. Seizures can also be multifocal, which means they're originating from several parts of the brain independently. Another important clue is the presence of a prodromal viral syndrome, things like headache, fever, flu-like symptoms. Other clues may be signs of cancer, as many of these syndromes are associated with cancers and tumors. Next, any personal history of autoimmune conditions. So these can include disorders like type 1 diabetes, lupus, rheumatoid arthritis, certain skin conditions like vitiligo. So this can be an important clue because people who already have an autoimmune condition can be prone to developing another one like autoimmune epilepsy. So as we mentioned earlier, new onset seizures are a common finding in autoimmune encephalitis, which we refer to as autoimmune epilepsy. So seizures are common, especially when the temporal lobes are involved. And in this picture, they are, the temporal lobe is highlighted as this kind of green structure here. So the temporal lobes are involved in functions such as processing memory and emotions. And so it makes sense that some symptoms of temporal lobe seizures produce odd feelings or emotions. And temporal lobe seizures can present as what we call focal seizures, during which the person can maintain some awareness. And these can progress to bilateral tonic-clonic seizures, which are also commonly referred to as generalized or grand mal seizures. So a little bit more about temporal lobe seizures. During a temporal lobe seizure, a person can experience a variety of sensations. Some people will have auras, which come right at the beginning of the seizure and can act as a warning sign before the person loses awareness or consciousness. They usually consist of an unusual sensation, such as a déjà vu experience. Déjà vu roughly translates to already seen, and it refers to a sensation where you feel like the environment is familiar or that you've experienced it already. Some people can also have jamais vu as part of their aura, and jamais vu means never seen. So it refers to the sensation that the environment is very new and unfamiliar. Auras can also be a strong emotion such as fear, anxiety. Some people report a sense of doom. And then other people can describe a strange taste or smell, which are typically unpleasant. And some people may also describe an abdominal rising sensation, so as if they were on a roller coaster and they felt their stomach lifting. These auras can occur on their own, so they can be isolated or they can progress. And when they progress, they can cause symptoms such as loss of awareness or staring. Some people will have automatisms, which are repetitive movements. When it involves their mouth or face, they can have lip smacking, swallowing, chewing. These automatisms or repetitive movements can also involve the hands. So some people may have movements such as like finger picking or rubbing their palms together. And in some cases, the focal seizure will progress to bilateral or generalized tonic-clonic seizure. And these are the seizures where the patient loses consciousness. They can have whole body convulsions. And then after the seizure, the patient may have a post-ictal state where they feel or experience a period of confusion. They typically have a memory gap where they don't remember what happened. And they may feel very sleepy or drowsy afterwards. So we'll move on to diagnosis now. So how do clinicians make a diagnosis? The most important thing to consider is the clinical findings and the presence of various symptoms that we discussed earlier. Most people will have an MRI of the brain to look for any signal abnormalities or lesions. They will also have a lumbar puncture where CSF or cerebral spinal fluid is obtained. The main key to diagnosis is to send blood and CSF to be tested for specific antibodies. But getting the results back from the antibody testing can take up to 2 weeks. So typically we don't wait to treat, and the treatment will be started before getting this confirmatory test back. Okay. So this is an image of how a lumbar puncture is performed. It's typically done at bedside by a physician who puts in a needle through the spine here, through the lower spine, to the space where we can extract some cerebral spinal fluid. And this is a very important test to be done because besides sending it for antibody testing, which can again take up to 2 weeks, there are other findings from the CSF that can indicate an autoimmune process. So things we commonly see are elevated white blood cell counts or proteins. And then other kind of diagnostic studies that can help are EEG and MRI, which typically show abnormalities in the temporal lobes. So EEG. EEG stands for electroencephalogram, and it's probably our most common diagnostic tool that we use in epilepsy. Essentially consists of putting electrodes around the head, and it can help evaluate brain waves and give the treating providers an idea of where the seizures are coming from. So getting an EEG is helpful in autoimmune epilepsy. It can help confirm seizures, and it can give us information about where the seizures are coming from. So I do have an example of an EEG here. This EEG contains what we call delta brushes, which essentially looks like they're like kind of paint brushes over the waves. And this pattern can suggest a particular antibody against the NMDA receptor in the brain. Okay. And this is just an example of an MRI from a person who had autoimmune encephalitis. So these are just two views looking at the temporal lobes. This one is looking kind of, if you imagine looking top down, and this one is looking, if you imagine if you're looking face to face at a person in front of you. But essentially, these are the temporal lobes. And as you can see, there is a signal difference, so it appears brighter where the temporal lobes are. So this is a signal abnormality in the temporal lobes, which in this case is indicative of inflammation or an autoimmune encephalitis. So I have here a condensed list of antibodies that we know. This is not an all-inclusive list, and research is still ongoing to identify more antibodies. But I do just want to point out that there are two general classes of antibodies. The first here are cell surface antigens. So this means that the targets of the antibodies are located on the surface of the cell, so essentially outside of the cell. If I go to the next page, arrow is not working. Okay. We also have a class of intracellular antigens, which means the targets for the antibodies are inside the cells. And one important thing to note here is that there is a column called response to immunotherapy. And so if the antigens are on the outside of the cell, response tends to be quite good. Whereas if the antigens are inside the cell, presumably these are harder to treat, and then the response to therapy is poor. Another column I want to draw your attention to is this column here. So this is the acute symptomatic seizure prevalence. So essentially, what percentage of people are developing seizures who have these antibodies? And as you can see, there is a range. So for example, in the AMPA receptor antibody, only 30 to 40% of patients develop seizures. But if you look here at the GABA B receptor, 90 to 95%. So nearly all of the patients with this antibody will develop seizures. The risk of developing epilepsy is higher if there's a higher seizure prevalence, then many of these patients can go on to develop epilepsy. And finally, I think this is an important column. It's a prevalence of a malignant neoplasm, which means prevalence of cancer. Again, there is a range. So for example, in the LGI1 antibody, less than 5% of these patients have underlying cancers. But in the GABA B receptor, the AMPA receptor, this prevalence can be up to 50 to 60%. And there is a list of some cancers that they are associated with. So I just wanted to spend a little time focusing on a couple of these syndromes, a couple of these antibody syndromes. So the first one is the anti-NMDA receptor encephalitis. So this is one of the more common of the autoimmune encephalitides. Patients will often present with significant psychiatric manifestations such as anxiety, agitation, delusions, or hallucinations. One example that I can give from my personal experience that I remember quite well was a patient who developed self-mutilation. So essentially he would bite his arms repeatedly, so we had to wrap his arms to protect him. In some rare cases, the disease may only have psychiatric symptoms. So it is important to consider NMDA encephalitis when someone has only psychiatric symptoms. Patients will also develop a variety of other symptoms, including seizures, movement disorders, sleep problems, language dysfunction. And we do see this NMDA receptor encephalitis in children. Reports have shown that they found this in children as young as 8 months, and they present similarly, but can have prominent early psychiatric symptoms. So there is a known association with a benign tumor called teratoma. Some reports suggest that up to 50% of adult female patients have an ovarian teratoma associated with their anti-NMDA receptor encephalitis. And these are usually treated with resection with surgery. Tumors in male patients are more rare, but there are a variety of various tumors that I've listed here that have been found with NMDA receptor encephalitis. And then I did include this picture of this book. So this book is called Brain on Fire, My Month of Madness, which was written by Susanna Callan. She was diagnosed with NMDA encephalitis back when the disease was just beginning to get recognized. And they did go on to make a movie based on the book, which is on Netflix now. But I thought I would just mention it here if anyone was interested in hearing the perspective of a person who actually went through this. And then briefly, I wanted to mention another antibody syndrome called anti-LGI1 encephalitis. So LGI1 stands for leucine-rich glioma inactivated 1 encephalitis. It presents similar to other types of autoimmune encephalitides in that it can present with memory disturbances and confusion and seizures. However, the seizures are a very specific type of seizure that we call faciobrachial dystonic seizures, and these can be resistant to anti-seizure medications. So I have a video of this type of seizure, just an interesting seizure.
Close your eyes.
Okay, let's try this again.
Close your eyes.
You can see it affects her face, her arm, her shoulder. They're very brief. It affected both sides of her body. So finally, this is the last part of my talk, which is to talk about treatment. So observational studies have shown that early immunotherapy can help seizures and improve long-term outcomes, which can include things like cognition or your thinking and memory. The current recommendation includes first-line treatments. These include IV methylprednisolone, intravenous immunoglobulin, and plasmapheresis. So these treatments are typically given when the patient initially presents and there is concern for an autoimmune encephalitis. These are given over the course of several days in the hospital. There are, so all of these agents of methylprednisolone, intravenous immunoglobulin or IVIG, and plasmapheresis, which you might hear being referred to as PLEX. All of these agents can work to counteract the autoimmune inflammatory response. If the first-line agents aren't sufficient, there are second-line agents available. Common ones are rituximab and cyclophosphamide. So I mentioned this a little bit earlier, but there are certain antibodies, particularly the ones that, that target antigens that are inside of the cell, that are less responsive to these immunotherapies. And so these patients may go on to develop epilepsy and may require lifelong medications with anti-seizure medications. However, people who have antibodies with targets that are on the surface or outside of the cell, these patients tend to be more responsive to immunotherapy. So if this is the case, the patients may not end up developing an epilepsy syndrome, and instead may need anti-seizure medications for just a short period of time, which typically we estimate to be between 6 and 24 months. So fortunately, most people with autoimmune epilepsy have resolution of seizures with a combination of anti-seizure medications and immunotherapy. For the small subpopulation that develops refractory epilepsy, they can go on to develop structural abnormalities such as mesial temporal sclerosis, and in the long run, they may end up being candidates for surgical options, which may include resection or neuromodulation. So even if these patients do end up developing refractory epilepsy, we can move on up kind of our scale of treatment and escalate treatment as needed. So for our conclusion, basically I've reached the end of the talk, but I did want to re-emphasize some key points. First, the identification of antibodies in patients with new onset seizures, particularly in adults, has led to the concept of autoimmune epilepsy in the recent years. The field is still evolving and we are still learning more and more about this as more research comes out. And secondly, seizures along with psychiatric symptoms and movement disorders are prominent features of autoimmune epilepsy. So if someone comes in with new seizures, but they also have some additional findings such as psychiatric disturbances or movement or other problems, it's definitely important to consider autoimmune epilepsy. And finally, identifying the possibility of autoimmune epilepsy is important because early treatment with any of those immunomodulatory treatments that we had mentioned earlier can alter the course of disease, especially in those patients who may develop refractory seizures or epilepsy. Okay, that's the end of my presentation. Thank you all for listening. I don't know if we have any audience members currently, so I don't believe we'll have any questions. So yeah, thank you all for listening so much. I hope that was educational and I hope that you learned something from it.
Thank you so much, Dr. Joo. That was very interesting and informative. Yeah, it looks like there are no questions. So we're all done for this talk. Thank you again.
Thank you.